Well, good afternoon, everyone. Thanks to DJ and others for having me come to the conference. It looks like it's a great agenda, and I hope I can live up to that intro. I'm not sure if anyone in Washington could provide very much clarity at this point, but I did fly in this morning, and I think DJ's mission for me is to look into the crystal ball and give you a little bit of insight about what might happen in the next few months. So I suppose starting off by saying I have no earthly idea probably isn't the best way to give you confidence in me, but here goes. Let's give it a try here, and we'll adapt as we go. So I wrote this slide up. I adjusted it from presentations I've been giving recently, and of course, as of this morning, it changed again. So I'll adapt on the fly here. For I don't know, a couple of months now, the Speaker of the House and the Senate Majority Leader, as well as especially the Vice President, and to some degree it would seem the President, had been on the plan of what they called repeal and delay, which was to move quickly on a repeal bill that could be passed with a simple majority in the Senate in particular, where normally legislation will require 60 votes. But they set up a procedural structure that allowed them to move with a simple majority bill and pass quickly a repeal bill that would have a 2 or 3 year delay in the termination of some of the major features of the Affordable Care Act. The idea being that they'd pass that quickly, and then they could work in the next year, and initially even they were thinking 2 years, putting together a replace program before anything happened on repeal. This was the so-called repeal and delay approach. I think myself and many others sort of pointed out that this is going to cause a lot of problems, and that one in particular problem is really related just to politics, right? Which is that you have a lot of members in the Congress who want to vote on repeal. And if you let them vote on repeal without putting anything else in its place, assembling a coalition for replace will be a lot harder than it will be on repeal, because that's where all the controversy is. And so if you let them off the hook, give them a repeal vote, let them do what they want to do to get rid of the current law without putting in place replace, you're risking very difficult road ahead on a second vote trying to assemble another coalition, perhaps with different people in it, to replace the law. So that's just an observation of how politics works a little bit. Of course, the other big problem with it was and is that it would destabilize the situation in 2017 and 2018. So before you presumably move towards something different in 2019, you might be dealing with a mess in existing insurance markets because the current law is still in place, but you would have done some things in this repeal bill that would have destabilized them further, in particular making it less likely that insurers would want to play in many of the markets around the country. So they've been hearing a lot about this over the last month, I think, the problems with this approach, and so they started talking about repeal and delay plus, where they would add some features to the repeal and delay bill to try to stabilize things in 2017 and 18 while they prepared a larger replacement bill for later in the year. And that's what's reflected in this chart I have up. This is their idea and their strategy over the last, I would say, 2 or 3 or 4 weeks or so. They've been evolving toward this, repeal and delay plus. But I think as they've gotten into that, they probably have realized, probably working with the analytical agencies that they work with, especially the Congressional Budget Office, that it didn't make a lot of sense to do repeal and delay plus with just a mini plus. If you're going to do it, you may as well just add as much of the replace in that first bill as you possibly can, because it's going to take a huge amount of energy, political, to get that first bill through. And so if you're going to do it, you may as well add a real replace plan, or as much of it as you possibly can assemble in that first bill and take care of it all at once. So the latest idea is to actually move a repeal and replace bill somewhat in combination in early 2017, maybe over the next couple of months. Now, a couple of things to say about that. You'll read about this, I guess, in the papers in the next day or two. One is that, not so easy, probably, okay? So it took the Obama administration working with the big majorities in the Democratic Congress in 2009, a year and a half to do the Affordable Care Act. And so all the political compromising you have to do probably can't be done in 2 months, okay? Just imagine if you're going to move toward a Medicaid, I won't call it block grant, probably per capita payment program, between expansion and non-expansion states, Texas and New York, for instance. How do you get to some kind of compromise in terms of the level of payments to the states in a very short period of time? There's a huge amount of money involved and a lot of passion, so it seems to me that that's unrealistic that they could do it all in a 2-month period. So they're moving forward. I think the good news is they seem to be recognizing that just focused on repeal is probably not the way to go. And I would say, I say this publicly all the time, which is that here you have a situation where people who ran for office on a platform of doing something very different in healthcare won. Now, they didn't really tell the public what it is they would do different, but they had something in mind that would be different from current law. And they have a lot of pent-up ambition to do something. So their energy and passion and enthusiasm and ambition should be put into what direction do they want to put into American healthcare? How do they want to reorient it to make it better and improved for all Americans over time? And I think the more they focus on the replace aspect of repeal and replace, the more they're going to end up having to put their energy and ambition into that part of it, and that's all to the good. But there's going to be bumps in the road ahead. Now, just from some articles I read today, what is it that they might put into this first repeal and replace bill on the replace side? It's very vague at the moment, but they had 4 categories listed. One would be, and they've talked about this, a new high-risk pool system. My own thought on that is that high-risk pools in this context might be their way of working with the insurance industry to try to create the environment to allow insurers to participate in the exchanges in 2018 in particular. I mean, they're very worried, I think rightfully so, about making sure the whole country has at least one choice in the exchanges in 2018, because whatever they do probably wouldn't be effective until at least 2019. So how do they make sure people have, in the individual insurance market, options they can select from in 2018? You got to do some things, probably now, to try to create an environment to allow the situation to stabilize a little bit. And I think high-risk pools is their answer to that. I think they're also going to try to do some HSA liberalizations in this first repeal and replace bill. There's talk of actually trying to do the replacement tax credits for the premium credits that are available through the ACA. These would be redesigned and different from the premium tax credits, structured differently, and probably not quite as generous at the low end as the ACA. So that's a big hurdle they would have to cross. And then Medicaid reform, as I already mentioned. They're talking about trying to put it together very quickly, work through the governors, work through all the different distribution issues that are associated with that, and do something to give the states a lot more flexibility in return for more fixed payments from the federal government. So something that would get away from the federal matching system to financing Medicaid toward a fixed payment system. But as I indicated earlier, I think it's likely to be on a per capita basis, not a fixed complete block grant. Anyway, those are the things they're talking about on this new version of repeal and replace quickly in early 2017. I'd also note that the Trump administration seems to be moving toward issuing a regulatory change, and this will be the first of many, in this program. And it would be designed to also try to create the environment that would stabilize the exchanges in 2018 in particular. And the reporting on this is in the public records, not something I know off, from any other source, but just in the public reporting, they're talking about doing mainly three things. One would be to tighten the special enrollment periods. The insurance industry has asked for that a number of times. They asked the Obama administration for it. They've asked the Trump administration for it. These are those periods when people that didn't go through the annual open enrollment try to get into insurance during a special exemption for themselves. I think this rule would try to create more criteria that were more stringent about who would qualify for those kinds of enrollment periods, because you don't want everybody in the country just using, last-minute sign-ups to pay for health expenses. They'd shorten the open enrollment period generally, probably for 2018, from, I think they ran it for 3 months this year, down to maybe 6 weeks or so. And then they tried to widen the age band for the premiums that can be charged in the market from, as you know, it's 3 to 1 now in the law, and in a let the lawyers fight this one out in some kind of approach that may pass muster with the lawyers. They would try to widen it to 3.49 to 1, right? So 3.49, we all did 8th grade algebra, rounds down to 3. So that's the talk about what they might do on the regulatory front to also help improve the situation. Now, there's some big issues outstanding with all of this, and I think the number one issue really is how do they handle the individual mandate in 2017 and 18, and how do they handle the fact that if they proceed to eliminate the tax associated with that mandate right away, probably in 2017, but effective permanently, if they do that, the Congressional Budget Office is going to very likely say that that act alone, just changing that, would add 10 or 12 million people to the numbers who don't have health insurance in 2018. And so you're looking at a pretty public debate, and opponents of the repeal, namely the Democratic Party, is going to say, hey, wait a second, you guys are moving forward with a plan that increases the number of uninsured by 10 or 12 million people right away in 2018. And so this is going to be a big political firestorm around this, and the question is what happens then? Do the Republicans in the replace portions of repeal and replace do enough to get CBO to say, well, it's not 10 or 12 million, maybe it's 1 or 2 or 5 million? That's one thought. Secondly, or do they just come forward and do it anyway and say, we think CBO is wrong, this actually individual mandate hasn't been that effective, we don't think that many people will drop out, and they proceed anyway with getting rid of it? I think that's a big open question and hasn't really been resolved. It's an analytical question. First, what is CBO actually going to say? What's in the replace portion? Does it have a material effect on this question? So stay tuned for that. I think that's a key marker in this next couple of months. The second aspect that is related, of course, is how does the insurance industry react to it? They've asked for these changes in the regulatory front that I just talked about, but there's a lot of unease in the insurance industry around if you get rid of the individual mandate, what exactly will happen? Even their own actuaries are a little uncertain about it. There's not that much data or certainty around it to know for sure. So what happens if they get rid of it? Not just in an estimate from CBO, but actually on the ground, will insurers participate in 2018 if the mandate goes away and the insurance rules do not? Again, an open question that really is going to have to be resolved and thought through. Another big issue outstanding here is this House lawsuit around cost-sharing subsidies. I'm presuming a little bit that this audience, who's very knowledgeable, will know what I'm talking about, but this is that lawsuit where the House of Representatives says that the spending associated with the cost-sharing subsidies that goes into low-income households below 250% of the federal poverty line in the exchanges, that additional subsidization of their coverage through the cost-sharing subsidies was done illegitimately by the Obama administration, that there wasn't an actual appropriation for the spending, and before they can spend the money, you need Congress to actually approve an appropriation. Now you have an administration that's probably pretty friendly to that legal argument from the House of Representatives, which, by the way, at least in one court, district court, had a judge agreed with the House. So if the administration agrees with the House in that case and maybe withdraws their objections to the suit, then what happens? If that money went away right away, everybody pretty much agrees that the exchanges would unravel almost pretty much overnight. So that seems like not a very good solution. And I don't know if they'll have the ability to separately make this appropriation easily. So how does the administration and the Congress work through a dance of legitimizing, in effect, this very big payment that's part of the current law program? How do they do that without compromising the principles, so to speak, around the lawsuit that they filed? So we'll see how that plays out. Another big open question is how much of a replacement bill actually can get enacted in a streamlined reconciliation bill. That's the bill that is allowed to be passed in the Senate with a simple majority vote. Much of their strategy hinges on trying to enact a pretty big replacement bill through reconciliation, because they are anticipating pretty much unified Democratic opposition to what they want to do. So they have a big question is how much can they actually do through that bill? You're not really supposed to be able to do anything that's not budget related. And I think we all know that in healthcare, a lot of it is regulatory and not necessarily direct spending and taxation, especially on the insurance side. So they're going to have to work through that and figure out if they can actually pull together a bill that could function and make it through that kind of a process. So that's another big open question. And then finally, if there's some things that they can't pass in reconciliation, is there any way to, in this environment to try to make it bipartisan and get some Democratic support for a bill that requires 60 votes in the Senate? And I haven't seen anyone present a viable legislative strategy that looks like it would at the moment. Because of the rancor in Washington right now, it looks and feels like the situation we've witnessed for the last decade is going to continue and worsen. So the partisan opposition about just about everything that comes up is pretty intense and means that the ability to do anything on a bipartisan basis is going to be quite difficult. Now, in that video that I had forgotten about that they showed before we started here, I mentioned that there are some plans out there that are probably worth looking at in this environment. So people often will say, well, what is it these guys are actually thinking about? Do they actually have any real plans? Now, I think it's pretty clear at the moment that it's not one plan, that there isn't universal agreement around any particular one approach, and they're letting lots of members are coming forward now with ideas because it's now a real question. But in terms of people in a position to actually do some real leadership in this area, there are a few things to look at. One would be, of course, the Speaker Ryan and the House Chairman released a plan last June, so it's not that old, and it's they called it a Better Way Healthcare Plan. It wasn't in a legislative form, but it was a blueprint, a white paper. If you want to know basically what the starting point is for replace, that's probably the best place to go. And it has a number of features to it that I'll talk about in a minute. There's another bill that's probably worth looking at, which was introduced by one key player in the Senate, Senator Orrin Hatch, who's the chairman of the Finance Committee. So he's like the new, if you remember from the ACA days, the chairman of the committee was Senator Max Baucus, and he was really instrumental to passing the Affordable Care Act. Well, now the chairman is Senator Orrin Hatch. He's the chairman of that committee. And if something is to be done on replace, he'll end up playing a huge role in what is done. And he ended up, a couple of years ago, he introduced a bill with a Senate colleague, Senator Richard Burr, and Congressman Fred Upton, they called the Patient Care Act, which was their version of replace. And not surprisingly, really, because of the politics of these things, it looks a lot like the Better Way plan that the House has. So you have the beginnings of a Senate version and a House version that look, frankly, quite similar. Further, you got the new, almost Secretary of HHS Tom Price. He presumably will be confirmed here in the next few days. He's got a bill that he's introduced several years in a row called the Empowering Patients First Act. It also shares a lot of elements between the Ryan and Hatch plans that I just talked about. And then you've got I got it flipped around. Oh yeah, no, it's Senator Bill Cassidy from Louisiana and Representative Pete Sessions from this great state introduced a bill that they have been talking about with a very much a state-focused approach where the states could decide if they want to retain some elements of the Affordable Care Act or whether they wanted to do a different market-oriented version of reform. There are many other elements to what they have, but that's structurally one of the big concepts they're pushing. And then finally there's the Trump approach, which so far we still just have basically what he said during the campaign, and we haven't really seen yet from the executive branch real clear guidance about what they have in mind. But on the campaign, there was a document that they put up on their website. I would say that the odds that the then candidate and then later president-elect had read or really thought about what that thing was were probably not that high, okay? So his connection to that plan I don't think is really strong, and it seems likely to me that he's open to anything that would kind of deliver on some of the basic promises he's made on the campaign trail. Okay, so what are we talking about here? What are some of the common themes across at least the ones in Congress? First of all, this is when I get to this part of the presentation, the people will often say, gee whiz, it looks and sounds a little bit like the Affordable Care Act. All right? And that's not surprising when you think a little bit about the politics, which I'll explain now, which is that our system here in the United States is dominated by employer provision of health insurance for the non-elderly. So unless you're on the very low end of the income scale and you're on Medicaid, the main way people get health care in the United States, or health insurance in the United States, is through their employers. And the politics of upending that or changing that in any big way are really difficult. There's 155 million people in employer-sponsored insurance arrangements. And basically, their attitude toward employer-sponsored health insurance is generally kind of like their attitude toward members of Congress. Let me take this metaphor a little bit explained. When you ask someone about their member of Congress or Congress in general, they generally will say, oh, Congress is terrible, they don't do anything, they're awful, et cetera, et cetera. But then you ask them about their local congressperson, not always, but in many cases people will say, oh, yeah, my congressman's okay, it's just that whole system over there is terrible, okay? A little bit with like health insurance and health care, especially employer health care. If you ask people about the health insurance system, they say it's terrible and awful, and I don't, it needs, some big changes. But then you ask them, well, what about your plan? Well, my plan, I get through my employer, it basically is okay, and I certainly wouldn't want to get rid of it in return for some untested new thing. And so if you start to talk about, hey, let's upend everything and we're going to change how employer provision works as well, basically the entire American middle class will come down on you like a ton of bricks and say, don't mess with it. So I think the reality is, and this was true under the Affordable Care Act, and it will be true under the replacement plan, is the first thing they're going to have to decide, and they will, is that, well, if you're in employer-based health care, you're probably just going to stay there. And we're going to leave you alone, more or less. Now they'll put, I hope, some kind of discipline on that system with an upper limit on how much you can spend on that kind of health care, but it will be kept in place largely without additional federal requirements. That new upper limit would replace the Cadillac tax, by the way, that was enacted in the Affordable Care Act. And then, this will also sound familiar, for people that are outside the employer system, you got to provide some kind of tax fairness to them as well, because there's a generous tax break attached to employer provision that if you get rid of the ACA, there isn't anything for people outside the employer system. So you got to provide, just as the ACA did, some kind of tax credit that's refundable for people on the low end of the wage scale that gives them a little bit of a tax parity in terms of the support they get toward their insurance. And at the low end of the wage scale, you probably have to do more than just the regular tax break. You're going to have to add even more money to it to make it affordable for that population. So if you look at a better way, Ryan's plan or the Hatch plan, they both have refundable tax credits that are different from the premium credits in the ACA, but conceptually, basically for the same category of people, people outside the employer system. Another big element is, what do you do about pre-existing conditions? And here, there's unanimity amongst the Republicans. They do want to get rid of the individual mandate, but they also want to do something that says, hey, if you've got a pre-existing condition, we're going to provide a pathway for you to have stable insurance. And the only way to do that is to flip the incentives a little bit and say, if you stay continuously insured, then you will be protected when you need to move from one plan to another in terms of the premiums that are charged for your coverage or the allowance for any kind of adjustments by the insurance plan in terms of your health status, both on the coverage level as well as the premium level. And in fact, importing into the new approach the same kinds of protections that are in the ACA, but not for folks who don't maintain continuous coverage. So there'd be an incentive to have continuous coverage. Now, I should say here that I think those who are going to come at this are going to say, I think rightfully so, that look, their plan in theory should be providing effectively, they won't use these words I don't think, universal coverage in the United States, right? If you have employer provision or you got Medicare or Medicaid, that's where you get your health insurance. But if you're outside that system, you get a tax credit. And that means that everybody in the United States, in theory, should be able to maintain continuous coverage and therefore never have a problem with pre-existing conditions. Now, of course, we all know there are lots of reasons why it doesn't work perfectly that way, but I think in theory, they're going to construct something that makes the argument that they're providing a pathway for everybody to have health insurance, at least financial protection for major medical expenses. And then, we'll talk about some of these other ideas maybe in the Q&A. I'm going to have to get through my presentation here, but I think Medicaid reform, we've already talked about. Again, it's very likely they're going to try to do something that moves away from the matching system. For those of you that work in the Medicare space, which I'm sure is most of you, maybe you can take a breather, because I don't think Medicare is going to be featured prominently in the legislative approach, because the Senate, Mitch McConnell in particular, has no interest in doing anything associated with Medicare. So I think any activity and change in Medicare will be likely more in the administrative realm, not through legislation. And then on HSAs, I think there's going to be a big effort to make, the big vision that they're going to try to provide here is that everybody in the country should be able to have at least catastrophic insurance for major medical expenses. And ideally, that should be coupled with large-scale enrollment in health savings accounts so that people have a means to finance the costs associated with care below the threshold for the catastrophic coverage. And so they're going to try to liberalize HSAs. They're going to try to incent more enrollment in HSAs. They're going to try to work with the employer side of this to really make HSAs even bigger part of the employer side. I think you probably all know that I think in the country now, roughly 40% of the non-elderly population is in more or less high deductible plans, right? So it's already a huge part of the system and it doesn't seem to be reversing anytime soon. So if you got that much in deductible plans, how do you finance it? So those are some of the main themes that they're going to pursue. In the rest of my presentation, I think we're going to need to talk with DJ to get Q&A going here. But let me just say one last thing, which is on delivery system reform. We get this question a lot. What are they going to do with all these provisions around trying to move to ACOs, bundled payments, and other things? Again, I don't think they're going to make legislative changes in the Medicare space, but I do think they will make administrative changes. So that movement to try to get higher value health services going, I think will continue on, but it's going to be recalibrated in a certain way. It's going to be less regulatory and more based on incentives, both for those providing services as well as those using them. And I think that will be built more directly into what they're calling delivery system reform. Thank you.
Sorry to have to stand up. I know you're sort of hitting your groove there, and people were with you. Thank you.
There's too many things to say, and that's too
Well,
short
and
of
if
time,
you're
yeah.
a policy geek like me,
Yeah.
I'll just listen. You know?
Right.
Let me ask a couple of questions. We've got about 10 minutes here.
Sure.
I think these are empirical, maybe not questions. Let me make some what I think are relatively empirical statements, and you tell
Are
me.
these facts? I don't know.
Alternatively, maybe they are. And you tell me if you see them the same way. Number one, and hopefully we'll get through 3 of these. We're not really talking about health. We're really talking about insurance reform. And to the extent that we're talking about insurance reform from the view of DC, we're talking about budgets to a significant degree.
Yeah.
There's some quality elements in this conversation, but mostly the quality elements relate to bending the cost curve. How do you see that? Is that accurate?
Well, I think there's a recognition among some people that the fundamental debate in healthcare really is about the productivity of the health system generally. I mean, I don't say this is universally, thought through and understood in the policy community especially on the GOP side. But I think there's enough understanding that the real game in healthcare is about increasing the productivity of the system. I mean, think of it this way: if you come forward and say we need to bend the cost curve, we need to take the trajectory down from 6 to 4 or whatever metric you want to put on it. If you do that without improving the productivity of the system, more bang for the buck, so to speak, by definition, you will diminish quality. In other words, if you cap something and the underlying productivity doesn't improve, by definition, just in an economic sense, you're lowering the quality of something. And so the only way to improve the system, slow down the pace of rising costs, and still deliver on the promise of higher quality continuously is to kind of bring into the health system continuous productivity improvement. Do more. I know this is what everybody says, it drives everybody crazy, but every year you got to do more with less. That's what every other industry tries to do. Health does try to do it as well, but it lags in its productivity improvement. And so the game is, what do you got to do to make that happen on a continuous basis? And the disagreement in Washington fundamentally is about who can make that happen. And there's a little bit of both, obviously, but one side thinks the government needs to lead the way on it, and one side says we need a little bit more on the incentive side, not so much government. So I think that's sort of where the battle lines will get drawn.
Wow, I'm a graduate. Used to teach economics and got a master's from Hopkins in economics. And I would love to challenge some of that. Maybe we could do that by podcast. It's hard, I think, to view healthcare within the industrial productivity lens, because we all end up dying, right? Sooner or later. It's a question of whether you got 90 years before you die or 40 years, and whether the system can still be productive or not productive, but that 40 and 90 is still relevant.
Yeah, that's true.
Second sort of question, from the view of DC, people care, if healthcare is largely about money, members of Congress, budget writers, generally care about things like Medicare because they are responsible for it. When it comes to Medicaid, they're responsible for the spending. When it comes to Medicaid, many policymakers view Medicaid as a blank check for states to come up with policies, benefits, and through the FMAP provision, the matching federal provision of funding, the federal government gets to cover blank checks with little to no or modest say in how that money gets spent outside of waivers and DSRIP and things like that. Is that FMAP view how you think policymakers view Medicaid?
Well, I think both sides in this thing are unhappy with the current arrangement. So the federal government sort of views it as we're spending all this money, and that entices our bureaucracy and us to impose restrictions on the use of it because we want to make sure, we're spending most of the money. We want we owe the federal taxpayers some accountability on it. The states then say, we're receiving this money, we have to put our own money in, and every dollar we get from you comes with all this baggage, And so kind of both sides, it's one of these situations where there's split political accountability, so nobody feels fully in charge. I think that's fundamentally the problem. Plus, when you have an FMAP the way we have today, on average, the federal government's paying about 63 cents on the dollar or something like that. So a state spends $1, 63 cents comes from the federal government. Reverse that process, though. Think of it the other way. Let's assume a state wants to save some money in Medicaid. If they save $2.50 in Medicaid by doing something, the first $1.50 goes back to the federal treasury. They don't get to put it in the state treasury. So if you're a policymaker at the state level, the incentive is not that great because you got to extract $2.50 of pain to help your own budget by $1. Okay? I think that's fundamentally kind of distorted decision making at both levels of government, which is why there's so much talk about getting away from the FMAP. Having said all that, it won't be easy, and there will be quite a bit of opposition. But I will say, if they're not going to do something on Medicaid reform this year, they never will, because you have a situation now where they ran on it. It was explicit. You've got 33 Republican governors. Probably all of them will say they want some form of reformed Medicaid system, even those in the expansion states. The question is how much money and what is it indexed at? And believe me, those are not small questions. But that's sort of where things stand at the moment. You probably will get some Democratic governors saying they'd be willing to do a per capita payment system if it was at an appropriate funding level.
Yeah. So when I look at the 2009-2010 Affordable Care Act debate in Congress, I think it's empirical. I think the political rhetoric doesn't reflect what my view. But when President Obama came into office, it took him about 3 weeks to get the economic stimulus bill passed. Really not even that much. And it took about 14 months to get the ACA passed from inauguration day to March 10th or 20th or whenever it was. They had 60 votes in the Senate. They were in a very strong position. To your point, Republicans are in a very strong position now. But they had to work through a 14-month committee process. My recollection was there were 5 bills that passed out of committee, 3 on the House side, 1 in Senate Health, 1 in Senate Finance. Ultimately, it was the Senate Finance bill that carried the day, and that was not really Obamacare, it was really Max Baucus care. And Max Baucus was a longtime senator from Montana, chair of the Senate Finance Committee, ultimately did not run for re-election because, in part, of this blowback from reforming healthcare as he saw fit. And he incorporated a series of Republican ideas in his bill. My recollection was he released a series of white papers in April. We're in February, and there's all of this gnashing of teeth to have repeal done and replace done by January 27th, February 20th, this day, that day. Doesn't a challenge like this policy challenge require the committee structure and a timeline that might be a year or 14 months or even longer just to get a bill?
Yeah, I mean, I'm not sure it needs to go that long. I mean, maybe the way to think about it is that depending on what you're working on, a newly elected president working with a Congress generally has a pretty short window to get major things done. And President Obama wanted to get basically 3 big things done in the first 18 months, and he got them all done. He wanted to get the stimulus bill done, he wanted to get the health care done, and he wanted Dodd-Frank done. And, so there were a lot of multiple trains going on there. And, what does the Trump administration want to get done? They want to get tax reform done, they want to get health care done, and they want to get an infrastructure bill done. So he's got 3 big things too. And they're saying they're going to try to get them all done in 1 calendar year. Now, I mean, I think it's really relevant that they're working with 52 Republican senators instead of 60 like President Obama had in 2009. So that's a very important fact. So they've got no room for error. The possibilities of this getting derailed and sidetracked and slowed down are quite high. There's no doubt about that. I'm totally in agreement about that point. But the one thing I would say is that if they get to October, November, December, and literally nothing has happened on healthcare, and there's no prospect of anything happening on healthcare, they're going to have a big problem, right? Because they've been talking about this forever, And it would be almost inconceivable that they would just leave the status quo in place indefinitely. So I wouldn't bet on that either. That there's nothing like, politicians deciding what is possible to force them to do what is possible. And, by the end of the year, they'll end up doing what is possible. Now, I don't know exactly what it'll be, but they'll end up doing something. Yeah.
Let me ask this sort of additional question. While the ACA passed in 2010, it was taken up in 93, went nowhere. It was taken up in previous iterations, like the Nixon administration, went nowhere. Tax reform has come up a number of times as well. It's been since 1986 since a significant reform took place. Healthcare was something that Republicans ran on, but is hugely complicated and maybe beyond some of the subject matter expertise of some members of Congress. Tax reform is an issue that was not central to most platforms, but yet many members of Congress have some subject matter expertise on it. Would you say we are more likely to have tax reform done during this first 2-year term, or more likely to have health reform done if we only got one?
If you only got one, well, I think, let me put it this way. They will never admit that they didn't do both, but something might pass on healthcare that they call repeal and replace, but you give a different name to.
Yeah.
And tax reform, I think they will do something pretty big on. Yeah.
I think the Democrats in Congress will call it Trump care, regardless of what it is, right?
It looks like the ACA they won't. But anyway, that's another.
Well, Jim, I appreciate you coming out here, and as I have said to you previously, there just are not enough thoughtful voices, in my estimation, on healthcare and health policy, regardless of the side of the aisle. And I think you're respected by left, right, and those that get run over in the middle. And so, keep putting your stuff out there, keep writing, and keep leading on this subject. Someone will listen to you. So let's give him a round of applause. Jim Capretta from the American Enterprise Institute.
Thanks very much.
All right. Thank you.